Good morning, everyone. This is Sean Stack with the Ohio Hospital Association, and welcome to the 11th of OHA's 2018 webinar series featuring alerts, program updates, and topics of interest to OHA's finance and PFS members. We are excited about this opportunity to increase and improve OHA's outreach to its finance membership, and we welcome comments and suggestions for future sessions. Today's program is being presented in cooperation with the Bureau of Workers' Compensation and OHA's corporate partner, Argos Health, and we will include Ohio Bureau of Workers' Compensation 2019 Hospital Inpatient Reimbursement Proposal and a hospital guide to unraveling complex workers' compensation cases. At this time, I would like to take a few moments to go over some housekeeping directives. This is a true webinar. There's no operator assistance. Meeting materials were distributed yesterday afternoon, but if you have any problems accessing those, you may contact Valerie Adams at val.adams, A-D-A-M-S, at ohiohospitals.org. And then Valerie will go ahead and forward you out those in a PDF format. If you want to wait, we will have those posted to our website under ohiohospitals.org, under Finance News, under our webinar links. We will be posting both the materials in PDF form and a recording of this session. This session does include a PowerPoint-driven presentation from both BWC and Argos Health. Attendees can electronically ask questions through either the lecture portions using the chat function or the Q&A function on your screens, and the presenters will respond to them in the order they're received at the end of each session. This session is being recorded, and a copy along with the meeting materials and Q&As will of course be available at OHA's Finance and Policy web pages under the links for Finance News, and then later in next month's edition of OHA's Finance and PFS newsletter by the numbers to our members. To kick off things this morning, I'm going to ask the Bureau's management team to begin by walking us through their 2019 Hospital Inpatient Reimbursement Proposal. Today from the Bureau of Workers' Compensation, we have Yvette Christopher, the Director of Reimbursement and Coding. Yvette has been in the medical field for 26 years, starting her career at BWC in 1991. Yvette was part of the team that designed the Health Partnership Program and developed medical policy of the program. Yvette then shifted focus to the private sector and held leadership positions in practice operations for over 18 years, while serving as a practice administrator, chief operating officer for a large cardiology practice, and a 45-provider multi-specialty practice. Yvette's experience included restructuring practices, implementing electronic medical records, and providing practice operational and revenue cycle management. She returned to BWC May 2016 to lead the reimbursement and coding policy team, which is responsible for developing fee schedules and associated reimbursement policy. Yvette has a master's in health administration and bachelor's in psychology from The Ohio State University. Yvette also holds board certification as a certified medical practice executive. And then secondly, from the Bureau, we have Lisa Landon, who has been with Ohio BWC for over 25 years, where she has worked closely with the hospitals and other medical providers. She has held key roles in implementing the IPPS and OPPS methodologies for the workers' compensation system, and is a senior lead of the reimbursement and coding team. Prior to her employment with BWC, she was a manager of patient registration at a Columbus hospital. She is a graduate of the Ohio State University with a BS in Allied Health. So without further ado, let me turn this over to Yvette and Lisa to kick us off for the Bureau's 2019 IPPS proposed rules. Yvette and Lisa? Are you guys muted?
Can you hear me?
There we go, thanks.
Okay, great. First, I'd like to thank Sean Stack and the Ohio Hospital Association for inviting us to do this webinar. We've had a long-standing relationship with OHA, and we're very pleased to continue that. I'd also like to thank Sherry Bearden for agreeing. This is the second year that Sherry has partnered with us to put on this presentation so that we can make it interesting and that providers can understand a little bit more and get their questions answered with respect to workers' compensation services. And as Sean had mentioned, Lisa Landon will be assisting me through this presentation and we'll be tag teaming as we go along. The first thing, I would just like to go over what we're going to be reviewing today. So as Sean mentioned, we're going to do an overview of the hospital inpatient reimbursement methodology and the proposed 2019 methodology updates. As well, we're going to talk a little bit about some of the policy updates, including opioid use disorder treatment and telemedicine, as well as some other things that could affect you as a hospital, or if you have, if you manage some employed physician groups. A background on the inpatient reimbursement methodologies. I want to remind you that Ohio Administrative Code 4123-6-37.1 is our inpatient reimbursement methodology rule. It is published on the BWC web, and I have provided the link for that. I will in a minute show you how to access that as our website has changed. The rule is updated on a yearly basis, and the rates are effective for the entire rate year. No updates are adopted outside of the rule update, and our inpatient rule is effective for discharge dates on or after February 1st of each year. This is a snippet of our updated website, and I want to show you that there are two ways that you can access provider-based information. So the first, there's an arrow at the top for the menu, and the second is a larger icon at the bottom called provider. Both of those will get you there, but I'm going to walk you through starting with the menu. When you click the menu, it has a drop down, and as I've highlighted the areas, although you might be interested in all of those areas for purposes of the fee schedule, you can access that under the billing and reimbursement link that's there. When you click the drop down for the billing and reimbursement link, it brings up those four options: find a fee schedule, the billing and reimbursement manual, ICDs for billing, and electronic billing. So the electronic billing will provide you with the information that you need if you want to understand the 837 requirements in submitting your bills electronically to the managed care organizations. The ICDs for billing, and I know that Sherry's going to also talk about this, but this will provide you with our groupings of the ICD codes that so long as an allowance, a claim allowance, is within this group, you do not have to, for purposes of billing, use the exact ICD code that is allowed in the claim. The billing and reimbursement manual, and particularly Chapter 2 and a new Chapter 5, which will be referenced as new and updated policies, contains the relevant medical services and medical billing policies that facilities and providers would want to be familiar with. As well as Chapter 4 of the billing and reimbursement manual contains the specific billing requirements. So the Find a Fee Schedule is how you locate all of our fee schedules. And on this slide, this is the landing page. So when you click Find a Fee Schedule, you will first come to a copyrighted page where you have to accept the copyright. And basically you just scroll down to the bottom and then you click the link. And it will bring you to this page. And as you can see, I've highlighted, so we have our current fee schedule out there. And that's effective from February 1st, 2018 through January 30th. Of 2019. And then we have our proposed fee schedule, and I've highlighted the two pieces for the inpatient. And then as well, we maintain 2 years of expired fee schedules out there in case providers need to access those for purposes for billing. But I wanted to point that out so that you would know how to navigate back there in the future. In terms of the, I'm going to turn it over to Lisa at this time to talk about the background of the inpatient reimbursement methodologies.
Good morning. BWC's inpatient rule allows for several different reimbursement methodologies, which are based on how the hospital is enrolled with BWC. We enroll 4 different types of hospitals, as you can see in the first column of the table, and some hospitals might be enrolled under more than one provider type. For example, if an acute care hospital has a separate and distinct psychiatric unit, it might be enrolled as a 34 and a 36. And in those cases, the hospital would have 2 separate BWC provider numbers. So when a hospital submits their provider number on the UB, our system uses the provider type associated with that number to determine how the hospital is reimbursed. So in the next few slides, we're just going to talk about each of those in a little more detail. For acute care hospitals, reimbursement is based on the Medicare IPPS reimbursement rate. We purchase a grouper and pricer for the October 1st Medicare rates each year, and then we get the rate for each bill from the pricer, and then we apply a payment adjustment factor, or PAF, to that amount. The PAFs are established each year to reimburse hospitals at 114% of their cost on an aggregate basis. And our current formula is listed on the slide with our payment adjustment factor for DRG cases. Type 36 psychiatric and type 37 rehab hospitals are paid at the IPPS exempt rate. We multiply the hospital's total charges by the CCR to get the cost, and then we multiply that by 100 or 1.14 to determine the payment amount. If necessary, the payment is capped at 70% of charges. And then finally, type 35 detox hospitals. When we established our opioid detox rule, which Yvette will discuss in a few minutes, there were some hospitals that requested a per diem rate instead of the IPPS or IPPS exempt rate. These rates were established with their input, and we require hospitals opting for the per diem rate for the inpatient detox services to enroll as a type 35 and report the revenue codes listed on the slide. So looking ahead to our recommendations for 2019, the first is to adopt the Medicare 2019 final IPPS rule updates. We're also proposing to move to a single payment adjustment factor to meet the statewide reimbursement cost, payment to cost of 114%. If there's an outlier or new technology payment for a bill, those would be added after the payment adjustment factor is applied to the DRG base rate. And then finally, we are recommending adoption of a lesser of payment provision for inpatient detox services paid at the per diem rate. So the single payment PAF methodology, a little more about that. BWC contracts with a health economics and policy consultant, and that's KNG Health out of Washington, D.C. And each year they model our historical inpatient bill data using the Medicare proposed and final IPPS rules. And that allows us to set our payment adjustment factors, understand our utilization rates, and they also advise us on policy development. Since 2007, BWC has had a separate payment adjustment factor for cases that are paid at the DRG rate and cases that are paid at an outlier rate. KNG advised us that the current approach of having separate payment adjustment factors was not necessarily optimal for the system. And by using the separate outlier PAF, we were not encouraging hospital efficiency, because when the bill hit an outlier status, the higher PAF would be applied. KNG recommended adoption of a single PAF to allow payments to equal 114% of cost. And if that single PAF methodology is adopted, it will allow us to continue to meet our target of 114% of cost It increases payments for DRG cases, and those are 96% of our bills. And then, of course, it encourages hospital efficiency. So the next slide shows how this formula will be applied. So the first bullet is the Medicare formula, of course, the DRG rate, plus any outlier add-on payment and any new technology add-on payment. And we are proposing to apply that payment adjustment factor to the DRG rate and then add the outlier or the add-on payment. We feel that this more closely reflects Medicare's methodology for reimbursing these cost-based provisions. So Yvette will discuss our last 2019 recommendation.
Our final recommendation for 2019 is to apply the lesser of payment provision for inpatient detox. This will pay the providers the lesser of providers' charges, negotiated rates, or fee schedule rates for inpatient detox services paid under the Type 35 detox hospital. I want to be clear that this lesser of provision is only for the per diem detox services only. This does not apply to IPPS providers. And it will allow us to maintain a consistent approach to all of the BWC's fee-based reimbursements, including professional provider. I wanted to expound a little bit more on detox services, as currently we think that this is a service that is going underutilized. So for opioid use disorder treatment, BWC actually has a rule, and it's 4123-6-21.7. And this rule has been in effect for almost 2 years now. And it allows the Bureau to pay for up to 18 months of treatment for opioid use disorder without having a claim allowance. So this 18 months includes inpatient and outpatient treatment. So within that time period, we will allow up to 30 days of inpatient treatment, but that 30 days does not need to be consecutive. And so if the patient needs to go back to inpatient, they can do so so long as they haven't exceeded the 18 months without having that claim allowance. We also have an opioid use disorder treatment policy that is available in that new chapter in the billing and reimbursement manual. So if anyone needs additional information on that, our policy is specified in detail in the billing and reimbursement manual through those links that I showed you earlier. As a reminder, for opioid use disorder treatment, the assessment and the treatment must be separately prior authorized through the managed care organization. There is a specific assessment code that the addiction medicine provider would bill on the CMS 1500. Once that addiction specialist evaluates the patient, they would identify where that injured worker would fit in terms of the ASAM criteria. The ASAM stands for the American Society of Addiction Medicine, and based on our rule, we must use the ASAM criteria in order to justify a specific site of service for the injured worker. Once that is identified, the managed care organization would then authorize treatment based on the ASAM criteria level that has been identified. For the treatment, the facility that is intending to render the service may also submit the C9 in conjunction with the physician of record. For outpatient treatment, we do have specific local level codes that are identified in our outpatient rule. As well, those same codes are provided for on the professional provider fee schedule rule. I didn't spend a lot of time with the outpatient information in here since we were talking specifically about inpatient, but I did want to still mention it, that those local level codes are the only codes that we will allow for outpatient services, and they are listed for intensive outpatient treatment and for partial hospitalization.
Yvette, those can also be found in at OHA's website. So if folks want to go into our website and do a search engine, I have published those out there last year when they were released. I want to second that Yvette's very important notice that these codes are being underutilized, and I really encourage hospitals to use these codes in regards to billing patient care under BWC in the best interest of the patient and the department to let them know that these services are being utilized when they are in an outpatient setting.
Thanks, Sean.
Mm-hmm.
Lisa provided this slide earlier, and I just wanted to reiterate so that we're trying to reduce some confusion with respect to how providers have to be enrolled. So the type 35 for a drug and alcohol hospital, hospitals have the option of enrolling their treatment facility under type 35. On an inpatient basis, if the hospital wants to use the per diem codes for the per diem reimbursement, and Lisa showed that to you earlier, and I will show it to you again on the next slide. For those per diems, the hospital has to have a separate suffix and has to be enrolled as a 35 to bill those codes. The per diems will not work under any other provider type. Now, after saying that, the hospital is not required to enroll as a type 35. If the hospital has an addiction medicine program and provides that under the acute care hospital, that is perfectly acceptable and would be billed and paid under the DRG methodology. And the same for the psych hospital, would be paid if they're billing using the suffix that is for the type 36 psych hospital, you would get paid under the psych methodology for those services. And for outpatient, you do not have to separately enroll as a detox hospital, as the local level codes are billable on the UB04. As I mentioned, these are I just wanted to reiterate about the revenue center codes that are the only codes that can be billed using the type 35 detox hospital and the associated per diem rates for those services.
I have a real quick question for you, Lisa. What happens if they get those revenue codes wrong? Those will deny. Do you know what they'll deny as?
I don't know, Sean, but we can find out and let you know.
If you could find out, we might want to look into that and have hospitals just look to make sure they have their system set up correctly. They could back into those and make sure they're reporting those correctly for you.
Okay.
That might help us all out, help you out as well.
Okay. Next, I wanted to highlight another policy that we paid for, telemedicine services. So telemedicine services are currently reimbursable to hospitals and to physician providers. Are services that are identified on the BWC's professional provider fee schedule, and I have that link there. It's 4123-6-08. It's also available through that same website landing page that has all of our fee schedules published together. I want to highlight that the reimbursement is limited to 41 evaluation and management codes as well as psychotherapy services. So if you have, we will allow, part of those codes include inpatient and outpatient. So if the patient is in your hospital and has to connect, say for example, for stroke services or for other services where you do not have the specialty care at your hospital, those are included within those 41 codes. I want to make note that we do follow Medicare for the originating and distant site requirements. Where we deviate from Medicare is that we do not have the geographic limitations. So telemedicine can be provided in an urban area as well as rural. We also do not have any kind of mileage limitation. So the provider's office can be located 2 miles down the road from where the patient is at the originating site. We also differ from the perspective that we allow, as an originating site, an employer's health clinic. So we do have some telemedicine vendors who are interested in partnering with employers, and so that injured workers can receive services without having to leave work at the employer's health clinic. So that is another deviation. We do pay originating site facility fees for, so if a hospital is providing an originating site for an injured worker to connect with a specialist for services on an outpatient basis, we would pay the hospital for billing that, and that is Q3014 is the originating site facility fee code. If the injured worker is an inpatient, or if the injured worker resides at a skilled nursing facility, the originating site facility fee is not payable. We do have billing requirements outlined in the billing and reimbursement manual, and actually the telemedicine policy will be published in 2 weeks in that new chapter. So right now you won't find any detail in the billing and reimbursement manual, but that will be out there in 2 weeks, specifying in more detail some of the things that I've just mentioned. Some final policy updates and reminders that we wanted to provide to you, just from recent questions that we may have received. So our area also manages a medical policy email address that when providers usually call in, we have a provider hotline, and if the frontline folks answering the calls either have policy questions that they need clarification on, they will pass that information on to our team to handle. As well, some hospitals do contact us directly, and based on some of those questions, we wanted to kind of highlight some of the issues that we've received. So for 2019, we will be updating the ICD-10 codes as of October 1st. But as a reminder, the managed care organizations will assist hospitals to crosswalk inpatient claims until February. So within our inpatient fee schedule, the system will not accept the new codes released October 1st until February 1. So the managed care organizations will help you with that. And as well, the same thing for outpatient. Our rule for outpatient does not change until May 1st. And so even though BWC has adopted and will be making claim allowances based on the new codes as of October 1, the system for outpatient will not recognize those codes until May, and managed care organizations will have to help with the crosswalking back to the former code until that time. For any hospitals that have chronic pain programs, we want to remind you that this is a service that has to be billed using an all-inclusive local level code, and it is a per diem rate, which is all-inclusive for those services. So BWC for chronic pain, if a chronic pain program is authorized, does not accept unbundling of codes for that service. Chapter 4 of our billing manual does go through our accepted bill types. But as a reminder, we've had some managed care organizations comment lately that they've had some difficulty with the bill types 115 and 135. When those are coming in, they can only receive those in hard copy submissions. As right now, our system doesn't accept those bill types electronically. If your hospital also bills for a physician practice, I want to make sure that the information gets to those folks who are doing the billing, that BWC does not permit incident to billing. We do have that stipulation in our professional provider fee schedule rule, but I do want to mention it because I know we do have some instances where that does occur and the providers seem unaware of that. If you're billing for provider-based departments, I want to also remind you that we require the use of the PN and the PO modifiers as applicable. And Sean has done a great job with helping us to educate hospitals over the past year because we have noticed an increase in the use of those modifiers. For home health, hospice, and nursing home services, if your hospital does own one of these type facilities and you do bill, we do not allow that billing on a UB. There is a separate enrollment that's required, and those services are billed on the CMS 1500. So that concludes our discussion with respect for those updates. And if you have any questions, we would be prepared to take those at this time before we turn it over to Sherry.
Is that one quick question, or Lisa, whoever wants to take this one? Is there any movement or is there any thought to adopt those codes when they're released in the future and not delay those new code sets? Several months that you delay those.
We haven't talked about that in detail. We understand it is an issue for hospitals and for MCOs. With our rulemaking process, we would have to build that somehow into our rule development each year. So we can definitely take a look at that and maybe talk with you even further about how we could best accomplish that.
Yeah, I wonder if that would maybe help with some of the confusion from the hospitals, because they're releasing those codes on all the other claims, and it might alleviate some pressure on the managed care organizations too in the future, if we could possibly put our heads together and figure out how we can do that. One question that just came through, I don't know if you saw it, is how will BWC pay for GME and IME? Medicare pays IME on a claim-by-claim basis, but GMA is paid through a PIP payment. How does BWC reimburse for IME and GME?
We reimburse for IME on a claim-by-claim payment, just as Medicare does. The DGME is also paid on a claim-by-claim basis. I think I have the formula here in my notes. The formula is in our rule. Give me a second here.
So while she's looking that up, guys, for those of you who kind of need maybe an association on this whole process. So think of, I know we don't think of BWC like Medicaid, but in Ohio, think of BWC in reference to medical education like Medicaid. They pay IME and GME not like Medicare. They pay them like Medicaid, where they pay claim-by-claim basis. That's how Ohio Medicaid reimburses you for IME, GME. That's how BWC reimburses you the same way through IME, GME. If that helps assimilate those two.
So I do not have that formula with me here, but it is in our rule, which is on our website, and it is spelled out exactly how we calculate that. We pull the data element from the HCRIS files each year, and then we post, we apply our payment adjustment factor, and we post those values for each hospital on our website.
Great, and I can pull that and post that to our website too. I know where it is. Now, I don't want to confuse anyone. Maybe I shouldn't have made that assimilation. BWC does pay on a claim-by-claim basis like Medicaid, but they use the same qualifiers as Medicare uses for GME and IME, where Medicaid does not use the same qualifiers for GME and IME. So payments are the same as Medicaid, but qualifiers are mirror Medicare exactly. I wanted to clarify that. Hopefully I didn't confuse people. Any other questions? I'll give you guys a few minutes. Any other questions for Yvette and Lisa? Why I think they're going to stick around anyway, but in reference to the proposed 2019 IPPS fee schedule, I think they did a great job on the few changes that are being made, and then of course to remind folks of some opportunities that we feel based on historical claims data that the department or the Bureau clearly did a great job in compiling, of areas where you might not be taking advantage or reporting correctly for services that are provided to your Bureau of Workers' Comp patients. Keep in mind that when you're talking about reporting these services and these claims for Bureau of Workers' Comp patients at your facilities, by not reporting these charges and these services through on a claim, and I know Sherry will definitely be getting on her soapbox here very soon if you've ever heard her speak, you're not only hurting yourself in reimbursement for the hospitals in setting yourself up for possibly 3 or 4 years down the road for a managed care plan that the patient may be also enrolled in to take that money back from you when they figure out it's BWC. You're also hurting your patients by not identifying them appropriately and keeping their claim open as it should be for that extended period of time as allocated by the regulations under Ohio Bureau of Workers' Comp. So I wanted to say that too. The name of the game, as Sherry's always said, is get that claim and get that service on the right track in the very beginning, the right conveyor belt, and then you'll prevent a lot of those denials downstream. So with that, I'm gonna go ahead. Oh, wait a minute, we have one more question while I was sitting there rambling. I'm sorry, can you repeat the updates in that we will be in chapter 2, 4, and 5? I'm lost on that question. Does that help you, Lisa?
It's in the billing and reimbursement manual. So let me, if I can't go back to the slide, but within the billing and reimbursement manual, chapter 2 is entitled Medical Services. And that's where our medical policy started. What we're doing is we're in the process of transitioning those policies within chapter 2 over to what is a new chapter. So we call it chapter 5 internally, but it's not labeled chapter 5 out there on the billing manual. It is labeled as new, updated, and revised policies. So there's a link at the very bottom of the billing and reimbursement manual. And that's where you can find, right, so from this screen, from that screen, yep, right there. If you would click on billing and reimbursement manual, it will take you to that landing page. You scroll down to the bottom, click the link, and then the manual will come up, and each chapter is linked, and that new updated revised link will be the last link that's there at the bottom. That's where the opioid use disorder policy will be, as well in 2 weeks, that's where the telemedicine policy will be.
Great. And if you guys can remember, I will try to put it on my calendar as well. And I will get that new telehealth Medicaid or telehealth policy out to the hospital, so they're all aware of that being updated as well. Okay,
and Sean, I also want to mention that we will be also doing a telemedicine rule that will complement the policy, and that rule, I believe, is going to be going to the board next month.
Okay. Great. All right. Seeing that there are no other questions, let me get out of these slides and we'll launch into complex claims here and turn this over to Argos Health. Okay, so next we are going to move into a presentation on unraveling complex workers' compensation cases. And this part of our program will be covered by Sherry Bearden from Argos Health. Argos Health is an emerging leader as a resolution company in the area of complex claims. They maximize claim reimbursement for hospitals, health systems, and physician groups by billing and resolving complex claims. Their services include workers' compensation, motor vehicle accidents, and VA claims. Sherry Bearden is a case manager and occupational health nurse by training and led one of the state's leading recovery firms specializing in the management and recovery of hospital revenue associated with the workers' compensation payers. She was part of the early initiatives of the Hospital Preparedness Program reform and has worked with all sizes and complexities of hospital systems to create workable processes. And at this time, I'll turn this over to Sherry and have her move forward with her presentation.
Thank you, Sean. If we go to the agenda today, I'll highlight it a little bit. He did mention my thought process of reviewing the BWC as an assembly line, starting with the identification of the financial class through the second level of hospital appeals. So in essence, kind of name the right payer when they first approach, most oftenly to the emergency department. If I was in fact in the registration area, I would like to provide some suggestions for correct payer identification for registration when they're unsure or when their payer directory could be outdated. It's crucial in order to start the first report of injury correctly, but in the MCO market, we've seen a lot of consolidation, and oftentimes the payer master at hospitals is not updated, for 10 years at times. So it puts a little bit of challenge on that front end staff. Remember, for each key process needed for workers' comp patients, it is part of the Ohio Administrative Code. It's actually the law. It's not just a nice thing to do, and that all BWC certified providers have agreed to follow these rules. These are not merely just payer preferences or plan designs. My goal is to provide some real-life hospital technical solutions, or at least have some entertainment of questions for the common denial areas to include technical coding discrepancies with allowed professional codes. I think the BWC has done an outstanding job in trying to understand both sides, on payer methodologies, but also on hospital reimbursement. So I think, through some of these real life examples, they bring a fairly quick resolution to items that we experience day to day. I would like to highlight some review nuances with authorizations and some of the BWC's newer programs that I will also echo are being underutilized. And then expectations of the requirements of workers' comp payers, the MCOs versus self-insured, and there are sometimes significant differences. And then open it up for any hospital-specific questions that either I can answer or definitely Yvette and Lisa could answer. And when we can't, we'll field it to Sean. So generally speaking, if I look at the total volume at a hospital, Ohio BWC, and if I even include Department of Labor, separate tax ID, Department of Energy, separate tax ID, in total, they only make up about 3 to 5% of a hospital's total overall revenue stream, yet probably create the most rework of any financial class. They do, or oftentimes can include a legal component that impacts care delivery throughout delays due to claim determination status, such as alleged allowed in hearings. These also impact payments and ATB groupings for this payer. So long-winded, when a director of PFS looks at their buckets, if you will, the 0 to 30, 60 to 90, sometimes our claims are still just in a hold pattern and nothing can really be done. So I would like to remind people that the Bureau does update their site daily when these claims move out of status. Self-insured are not obligated to update the BWC site, so oftentimes they might look like they're still in alleged status if there's been a state claim number, and in fact, they could be allowed. And so I think that, you know, you have to be a little patient because it's kind of crucial that everybody has party to the claim can decide if they agree that this condition did arise exclusively out of employment. There's an expectation that's unique in workers' comp that the treating provider right on the FROI is supposed to determine causal relationship of the alleged injury. So is it due to arising out of and in the course of employment? Now, that's not to say if the physician on the treating and on the FROI itself does not mark that box, which we see most oftentimes, that anything changes. It's just, it still will go through its due course of everybody involved gets to have their opinion on whether they agree to accept that claim or not. And why I even bring this up is if you do file your FROIs online, and every one of us who do that have tried to avoid this box, it does make you check if it is allowed. I mean, if it did arise out of employment or not. It's the causality box you have to mark yes in order to get the claim number assigned. But even if you mark yes, please recognize that it will go through the due process, that people do have their ability to vote in on whether they accept the case or not. And then the newer introduced programs by the BWC to meet the demands of the employee community definitely include detox services and then the presumption of causality for firefighter cancer, plus the numerous grants available for safety for the firefighter community, which for me has been a little bit long overdue, so I'm very excited about the momentum now. The patient, it would be for new patients with a possibility of a cancer diagnosis, and they would need to first fill out the FROI, and then there's an accompanying form of the C-265, which is very specific to the environmental elements the firefighter has been exposed to. So what makes this a little bit challenging for the technical hospital community is that cancer physicians are usually the ones that will fill out or help fill out this form, if you will, or give some additional diagnosis, and they're not terribly familiar with workers' comp principles. So I do encourage people to kind of reach out if you have employed cancer physicians under you, or you have large groups of cancer physicians. This would be something that I would be willing to come out and kind of educate staff on, because they need to start recognizing that there could be a causality to this. Okay, reporting the injury. This couldn't be more boring, but most important. So I jokingly call it the name the right payer, and we still, to this day, will have patients come into an emergency department and act like they have workers' comp and they have United Healthcare, like a Visa and a MasterCard. And so they think that they can say, oh, I don't want to put this on my workers' comp. I'm going to put this on United Healthcare. And the more we can educate patients, I encourage hospitals to have a patient's guide to workers' comp. We've written about 3 of them for specific hospitals because they cannot do that. It's very basic. It either happened at work or it didn't. So it's not to be confused. There's still a stigma that patients feel they might get fired if they fill out a workers' comp case. But with only a 1-year statute of limitation for a physician to fill it out and for a patient now to declare if it was work-related or not, it's crucial. And then the take-backs that are involved when it's done incorrectly is also very impactful to the patient's case. So, you know, we have to keep working on that. And so the other thing I will point out is the employer section. Now, the employer section, we get a lot of patients do a great job on the front section. When you start to go down, you see the employer section's further down, right? So with so many different types of employer situations, so you might have Firehouse Grill, LLC, but really it means they got hurt at Outback. It's really, really important for doctors and hospitals to understand where that patient works, because nobody wants to take credit for a claim that's not theirs. So the more you can fill that in, the better it is for the MCOs and then those in billing who are trying to get the bill out. I would say that, you know, I would probably spend some effort on the importance of the emergency department, at least getting a few fields. I don't care what the employee makes an hour. We could probably figure that out, but I do want the name, the social that would be written where we could maybe read it, and then the employer would be the most crucial part. Downstream, how this affects all of us is that without a claim number on a state claim, it'll sit in unbilled because we can't bill this without a claim number on it. So I've worked with hospitals that do a workaround, force a bill out, but it goes nowhere. So I'm not sure the value of it other than people don't get in trouble for having unbilled numbers growing, but it kind of defeats logic for me. So I think this is, you got to spend some effort on this repeatedly. The other thing I would tell you on, we can go to the next slide, Sean, determining the right payer. So the BWC updated their website, and it takes a minute once you start navigating, but I think the site is fabulous because it gives so much information right there in a question and answer format. But if I'm a registrar, my criteria for success is how fast I answer the phone and how fast I get people registered. I still recommend, if you don't know the right payer, which would be, I can totally appreciate that statement. You get somebody in from Bob's Body and Fender Shop, you have no earthly idea, you put it, you research it quickly on the Bureau site, can't find it. I would personally mark it as whatever your generic payer code is. And let me tell you why. I have the most empathy for 188 Ohio Comp because it's usually the first one on everybody's payer list. They get so many people that just pick it to keep moving through the screens to register. Well, now you've done that. There's nobody in your hospital system will know that that's wrong. So you're way into 30, 60 days before you get a claims denial before it was the wrong payer. So if you pick a generic payer, yes, they're going to sit, but somebody can at least be assigned to research those mid-level, like, you know, mid-assembly line. Hopefully it's not in billing where you do it at the end, but it's far better to do that, and it'll impact your claims down the road because the same patient could go on to therapy, and now we're picking the wrong MCO for therapy. The Bureau lists the self-insured employers, and so you can see where those claims should be sent, and they do not like, which is not news to all of us here, but the self-insured community, if it's a medical only claim, really prefer not to have a claim number. So they aren't thrilled when providers do a FROI online or any other way because they like being self-insured, and as long as they get their you know, UB, their FROI, and their notes with it, they will process the claim accordingly. So that's enough of the rant on the generic payer selection. Early provider opportunities. This has been published for forever, but just to remind everybody, because now I see in our hospital community, we employ many, many, many physicians now. So since this pendulum has swung the other way. My early days, I worked for Cleveland Clinic for 7 years, so this got to be real common for us. But now I don't see this quite as much as we employ physicians in this continuum. But anyone that sees workers' comp patients, you have the obligation to identify the injured worker's MCO, and it's supposed to be within 24 hours. So the Bureau provides several mechanisms, but you have to, number one, ask where are they employed at. The more heightened we become in HIPAA, the less we like to ask a lot of questions. But remember, when a patient signs up to say, I am saying that this injury is work-related, they're releasing the provider from HIPAA requirements. They're not releasing us as providers from PHI protection, but they are saying you can ask my employer questions because I'm saying it's causally related to the employer. The treating physician, so that could be in the emergency department, occupational health, primary care, orthopedics, reports the injury to the MCO, or if they can't find out who, to the BWC. There's several mechanisms. Faxing is the most probably common route that goes to the medical repository, and then everybody who's party to the claim can gather their information out of it. But again, I emphasize it's supposed to be from 24 hours from the initial treatment. So that's where I can say safely in a hospital environment may not happen, because the MCOs will call to see what the code is, and perhaps it's not coded within 24 hours. So if you send over the FROI with the medical without a code, it can delay things a little bit. So most times hospitals like to have it coded. Otherwise, the MCO will just keep calling daily, as it's a key area for them to include. So if it's within 48 hours, that's grand. So I would say then you can see as we go down here, though, how it starts to impact everybody's timeline. So then the MCO has to report the injury to the BWC, 70% within 3 days, 100% within 5. So there's scorecards that get tied to the MCO. So you can see if you're on the receiving end, you get some diligent MCOs that call daily to make sure you stay timely. This is why. I would also maybe channel some of these requests to one area so that you know within your own hospital system who is on point to get these things done. The Bureau, if you didn't do it online, will assign the claim number, and then it goes out to everybody involved to see if they accept or deny the claim. So you can see right here how long you have. Provider within 5 days of notice, they'll send a letter out on injury. Most hospitals now receive it via their lockbox, and then all the different parties are updated. If you look at why do you have to send medical, the employer has two pockets. The need to understand which the medical that goes with that UB or 1500, is it related to the workers' comp claim, or is it related to some other ancillary service? So I think it's important that they're just trying to validate each diagnosis code as providers bill them. Are they all tied to the workers' comp claim? Hence, they need to have all the medical to make those decisions. Self-insured are even, a little more aggressive at times, because there's the philosophy that if a self-insured pays for some diagnosis code that wasn't necessarily related, but once they've paid for it, they more or less have acknowledged that it was party to the claim. So there is a definite reason they need to have the medical included. You have questions up there?
Do you want to look at the questions now?
Sure.
Okay. We will take a second here and pause and look at our questions coming in. Is there a list of current MCO per Ohio employers? Is there a list of which Ohio employers are self-insured? Isn't that online, Sherry?
Yeah. So MCOs per Ohio employers. Yvette, do you want to, that's a search that you have, but go ahead. Is she there, Yvette?
I think so. Are you on mute, Yvette?
Yes. So I think you would have to search it individually. I don't know that there's a list of each MCO and every employer that they have.
Right.
You would search by employer, right? And it would map to the MCO?
Yes.
Right. And you could also submit a public records request for that information, but I'm just not sure that it's published. I will double check, and I will let Sean know if it is, but I think that's the two ways of getting it, through the search individually by claim, or through a public records request.
And then that is exactly right, how to get it. And then when you do the search, my recommendation on the search is put less information in than typing the whole thing out. So then you get a little bit broader, because you might not know exactly, Bob's Body in Fender Shop is really just, Bob's body work, right? So if you just put in Bob, then you probably will get every option under that. So that would be a recommendation. And then again, the self-insured is definitely there.
And I would recommend not to disseminate the question, but I would recommend not requesting a list or not referring to a list, because a list that large is going to change as employers leave MCOs and change MCOs, and your list would be so outdated in a couple of months that it might not be worthwhile anymore. So using that search tool is probably best. Next question is a doozy. It's pretty long, so this is great. Okay, so we have patients who come to the ED stating that the employer does not want us to report to PWC, but wants to receive bills directly. Are you saying this is okay for self-insured employers, but not for those with MCOs? I thought we were told we do not have the option to report. We must report, and it is up to the patient to have the claim closed if they do not wish to pursue with employer.
Well, I'll take the first part, and then Yvette, you can add to it. So this is a enigma similar to the 15K program. Okay, so some employers would prefer to pay the claim outright. So there is a claim number allowed already. There's a claim number established. The case would be allowed. So I would make sure the case is filed so that there is a legitimate claim number. However, if I'm the employer and I would rather pay the claim versus having it hit my experience rating, I'm totally fine with sending that bill to the employer themselves. So that would be my recommendation, is you can do that. I would also take that time, to be honest with you, to educate that employer about the Bureau's 15K program, because it's just a little more structured and then everybody's in the loop. But there's no problem with who pays the bill. It's just you have to intercept it in time before it would go to the MCO. Once the MCO pays and processes the bill, that data is already kind of logged in as far as in the actuarial formula towards experience ratings down the road. Hopefully that makes sense. Yvette, do you have anything to add to that?
No.
Next question, we are aware that we need to submit a FROI within 24 hours. However, if medical records have not yet been coded to the account because they are waiting on documentation from the provider, is it justified to hold the FROI until coding is complete?
So I'll answer, and then I'll have Yvette give. So my real life answer is we would hold it till it's coded, because it really doesn't do a lot for anybody involved to have it uncoded. Now, the challenge is if it takes a long time to get coded. So after 3 days, if it's still not coded, I would send the medical and the FROI to the MCO, who has coders on staff, and they're going to read it and figure out something. Where it gets messy is if a technical coder, for example, might use something like unspecified injury. That's not very helpful. Doesn't tell us where it is, doesn't say anything about it. It's a non-allowed code. Or a pain code. That's what the primary diagnosis comes in. The Bureau and the MCO are going to have a hard time with that. So if your coders turn it around quick, I would send it after it's been coded. But after 3 days, if it's still not coded, the MCO needs to have that data, and they will figure out something that is acceptable to at least get the claim started.
Anything to add, Yvette or Lisa?
The only thing I think that I would add is that, the injured worker can submit a FROI as well. And so it is possible that, and the employer can. And so these pieces of information could get to the MCO. So if you're holding it, we want the information submitted as soon as possible. I understand what you're saying in terms of for proper bill payment. I would just encourage to have as timely of information as you can. If you are holding it, I wouldn't do it for beyond the 3 days, but it could already be in process to where they're looking for that medical. Great. And you would want the most detailed medical there so that you know, you don't have to go back and start looking for additional allowances versus just having the allowance be correct from the start.
And what will happen in the situation? So if the hospital or provider decides to send it without it being coded, what in kind of in the day in the life is that somebody does call daily to say, do you have the primary diagnosis? Do you have the primary diagnosis? So, I mean, as long as your hospital has a mechanism for that MCO to call to get the diagnosis, not so much even related to billing, but just the actual, you know, diagnosis code itself. So hopefully we provided that solution. So
two other questions. If you cannot find the MCO, do we fax the Freud medical to BWC? If we cannot find the MCO, I assume through the search option, do we fax the Freud medical directly to BWC?
What I do is, it's not, if you can't find the MCO, I would call the employer. The employer should know who the MCO is, because again, you can call the BWC and list the employer, and then they can tell you, they can assist you with it. Once in a while, you will come across an employer who did not apply for workers' comp insurance. So the reason, at that point, then you can loop in the bureau to get involved to help the employer. But I would do that.
Can the employer request us not to report?
They can, but you shouldn't. So I would still report the claim, but if the bill, so that there's a claim number established for the patient's benefit, and then the employer is charged on the, you know, the actuarial figures. So if they want to minimize some of their financial impact, they should pay the bill themselves. Okay.
Okay, great.
So on my did you know slide, we already kind of covered this to death. And then the updated, which is not so updated anymore, but the revised code, all workers' comp bills have to be submitted and resolved within 1 year of date of service, which means you really have to focus on these claims, because you know, you don't want to have going for an additional allowance and there's 30 days left of the claim. And so I would, in that middle section, in that 6-month mile marker, make sure that you're doing all you can on anything to keep the claim moving forward towards resolution. We both have highlighted that the bill diagnosis, so this is moving forward. The claim is already established. It has a bill diagnosis for an allowance. It does not have to match exactly if you're on the technical side. So if I look at it this way, the professional side is what codes the bills. The technical services do not usually provide the initial coding in any way, shape, or form, diagnosis codes ever. So sometimes a professional coder and technical coder do not agree on the exact ICD-10 for that initial case. So in this situation, as long as it's related and it's within the first 72 hours of the date of injury, those cases can't be resubmitted for reconsideration and process. Because really we're just trying to do the right thing for the injured worker at that point in time and understand that they're close and it's a new injury.
Sorry.
That's okay.
We're locked up here. There we go.
Okay, the top common denials are still the same. You know, the diagnosis not allowed. There's a bill diagnosis is not allowed in the claim, and it can be used if it's pending allowance. So if claims are in alleged or in allowed appeal, or it can't be paid until it's in a payable status, which is allowed. Prior authorization needed, we see a lot. Prior auth happens sometimes when the patient comes into the emergency department, they present with certain allowances, but then, you know, they have additional situations arise and the physician treating or the hospital treating needs to actually provide a more definite diagnosis. So I give an extreme example of a allowance for a fractured femur. Patient, you know, is discharged, goes home and has leg edema and pain. They come back in, primary diagnosis is going to be leg edema and pain. It's not going to be a fractured again. And then the physicians treating are going to have to rule out DVTs and some of those other conditions. So they're going to send them for multiple tests along the journey. So those are examples where hospitals do not get reimbursed until you do an retro auth for all of these other diagnostic screenings that occur. And then oftentimes, say it ends up to be a DVT, the primary diagnosis is going to be that. It's not part of the claim. It'll need to get added to the claim so that that code is allowed. So then as the poor patient goes on to have, Coumadin clinic visits and such, it'll all be paid for under his workers' comp claim. Medical documentation needed is the examples we have talked about. They need more info to make a cognitive decision. Inactive claim, patients sometimes don't realize that if you don't receive treatment after a period of time, the claim becomes in an inactive period. So they might show up at an emergency department, and then that claim will need to be reinitiated with a C9. Non-covered procedures and disallowed claims. So disallowed claims, if there's a hearing, hospitals have one kind of option to wait and see how that goes. Disallowed claims, after it goes through hearing, they can move it to the next responsible party to bill them, and then you have proof that it was already considered under workers' comp. Okay, understanding coding. So this is probably, for all of us, the biggest rub that occurs. The Bureau is very code specific. And again, understanding the differences in commercial insurance. The reason is that the employer is assessed the charge for every code that is assigned to the case, because it's all talking about the causality of the claim, and it'll affect premiums down the road. So there's a lot of resistance. I shouldn't say a lot. There are some cases of resistance to add additional allowances because the employer, MCO, TPA, all of them are protective to keep the number of clear allowances at the least amount. Hence the reason you can ask for reconsideration on things that are close, that are causally related, but might be a one-time example of something that went wrong. So say the leg edema, we're not going to try, if that patient ended up with it not being a DVT and it was just truly leg edema causing the challenge, we wouldn't try and add additional codes, but we would ask for that bill to be reconsidered because it was symptomatic and clearly the patient had issues, but we didn't need to add the outcome of the diagnoses and the screenings didn't change anything. So if a code is causal related but not part of the allowed condition, that's the example I just gave you. You can ask for a one-time override situation. If the condition is chronic and you have the blood clot as the example, then you'll need to get those additional codes added. And BWC arranges the codes into numeric groups. They can, in that same group, they're interchangeable, and we told you where to find those. And same with the invalid codes. So the rub between technical coders, pro coders, I think it's very helpful to submit to hospital coding staff what are the BWC invalid codes, because most everyone uses Medicare, and these are different. And the reason the Bureau cannot allow symptom codes in a primary position is it's just that. It's a symptom, it's not a diagnosis. So pain is a symptom, and it doesn't show the root cause. And there's a whole list of symptomatic codes that does not give insight to causality. So I think, if you're looking at why, that's the why. Not that the pain isn't the primary issue, but something underneath it caused the pain. So when you're working with coding staff, it's helpful for them to have it on the front end so they can make kind of educated choices. The Bureau does a nice job of updating this, and then the Bureau follows on CPT coding. There are specific Medicare inpatient only codes for the CPT codes. So they follow the Medicare guidelines. So we've had a recent situation where a patient was allowed for an inpatient stay, it turned to an outpatient stay. The hospital only used an inpatient CPT code, even though the C9 got updated. So there's a lot of moving parts that make these cases rework. Okay, this is not terribly new. It's new though for the patient. So the patient used to have 2 years from the date of injury to file a claim. It would still start with the year that they were injured in, but it could have been 2 years later that they decided it was work-related. So the Bureau now has consolidated that. Both the hospital and the patient population only has 1 year from the date of injury to declare it's work-related and to get the claim completely resolved. There's a few exceptions to it, so we don't want to go over the exceptions, but this is even more important to you that with the emergency department. Instead of the patient saying, well, you know, I really don't think I'm that hurt, I'll just, you know, file it under my commercial. I think if it happened at work, these are not hard questions. Did it happen at work? Yes or no. The ones that get a little bit more tricky are the cumulative trauma, you know, carpal tunnel, back strain maybe situations, but I think we have to encourage patients to declare a little sooner and protect their interests, because if they decide, you know, after United Healthcare makes that decision for them or any other commercial provider, then you can't go back and change your mind, and then they would get stuck with that whole bill. So hopefully that makes sense for everybody. Okay, authorizations. There's nothing profound or terribly new on this, but the C9 is the authorization form and still requires the treating physician or physician of record to generate it. They're most often completed for technical services because the physician of record or referring physician are responsible to secure them. However, we still see the need for retro C9s, for examples like I gave where they have to go for additional screenings or lab work is done and it's not detected at the time that it is tied to the medications the patient is on. So they're going to do lab work to check for liver functions or kidney functions. So there are still retro C9s that have to occur. And I think when the retro C9s are filled out, you're going to have to declare that it, is for additional screening or some of that. So it's still a little challenging at times, and physicians, I know, get notified from the Bureau if there's too many retro C9s. So there is some opportunity for teachable moments, maybe not even on a physician-specific level, but maybe on a kind of group practice level, especially as again, hospitals employ more and more physicians. It requires a little bit of an infrastructure to assist on workers' comp because it is a little different than many other payers that they're familiar with. So this gets, surprisingly, this gets a little fuzzy at times on billing. And so I just put it up there, not to have any profound conversation, but, sometimes in conversation, when you think of outpatient, you think of in and out same day. And an outpatient encounter cannot exceed 72 hours. So, when you have observation and then outpatient, and so, I think it behooves all of us to get familiar with the laws. And same with the, fee schedule. So the additional fee schedule of ambulatory surgery centers, and there's some requirements there. So if you have the responsibility of knowing which, kind of how the patient flow is going, I would make sure that you're familiar with how the Bureau is reimbursing in all these different areas. I know as time goes on, they might look at a little bit of ease in how to do these, but for right now, inpatient, outpatient, ambulatory surgery centers, there's some specific DRG groupings that have some uniqueness that we talked about last time. So I just wanted you to provide these so you could find them. And I would say that the self-insureds adhere to these fairly closely as well. Okay, so the detox services, I will tell you, I see highly underutilized, and today was really helpful, I think, for everybody to clarify that you do not have to be a type 35 to provide the care. You have to be, you have to get the additional certification in the type 35 if you want the per diem rate. But even Sean and I were talking that we see probably one of the largest things is the local codes charges are not added to the charge master, therefore they don't drop on bills. So you know, you don't want to write these services off, you don't want to adjust them, you don't want to move them to a payer that they don't belong to. So there needs to be a process put in place when these local codes arise that they do get added so they are able to be appropriately utilized. The number one thing hospitals do is they move the money, and so we see, well, it gets denied for coding or charges, and then if there's a commercial insurer, they move it there, and then the commercial insurer denies it, and then they move it to the patient level. And so, you know, when there's so much mobility and a patient has workers' comp insurance and they have commercial insurance, somebody needs to take a step back and say, why is this denying when we have two, you know, legitimate payers here? And I would look at the patient as like next to never as an option, because trust me, they look at it that way. They say, I have two insurances, why am I getting a bill? And then I will also mention as a sidebar, workers' comp, you cannot balance bill. We have had that happen in recent days, which was a little surprising. So, so I would say on these local charges, you got to stay up with them because there are reimbursement opportunities. And then I would also do the departmental research on the these new areas that had not historically been part of BWC. So maybe, you know, how can you help them pick the right codes for the services they are providing? Billing considerations, real quick, for state-funded accounts, the provider number with the correct suffix has to be on the bill and the claim number on the bill. So a hospital is wise to put edits in place to hold them until those happen. All hospital services billed hard copy must be submitted, which is not shocking, on the UB04 using revenue center codes. Outpatient hospital services, a large number of revenue codes now require a corresponding CPT code, and they are listed in the reimbursement manual. Lines are, I have had this question, lines submitted on an outpatient bill with a charge of 0 are accepted and shall be priced accordingly, which usually they all bundle anyhow. So, you know, I would make sure you have that on there. And inpatient billing appeals. So hospitals may appeal coding changes and denials to the MCO BWC in writing with supporting documentation. And I would recommend including the ordering providers on these claims. So this long-winded is there is always going to be a rub between professional coders and hospital technical coders. So if I look at it objectively, the professional coder sometimes will put on the C9 what they anticipate the procedure to be. And then once the physician gets in there for a surgery or whatever, and it's more involved, and you know, we used to clinically joke it's the oh by the way situation that is always the most cumbersome. You know, so the physician gets in there, discovers it's something additional, and then the C9 is going to need amended. So if we send it to a technical coder, they're going to say, no, I coded with the correct claim, you know, with the correct coding on it, be it diagnosis and or CPT code. So instead of getting this quagmire, if you get to be in an impasse, instead of writing the whole bill off or trying to shove it to a commercial carrier, I do recommend to get the BWC involved. The MCOs have coders on staff, they have a medical director on staff, and so they will give their best recommendation, knowing that the Bureau has the ultimate decision based on what they see. But, you know, in these cases, you can plead to the Bureau. And this kind of goes on that we were pleased that the Bureau created a newer kind of designated process to get a second look by hospitals when an MCO denies, because we as hospitals are not usually part of the whole ADR process, and most of our issues are going to be coding related between the two types of coding. And then I think a lot of bill charge versus referred charge for a hospital when they kind of dump methodologies into their anticipated revenue models, if you will. They look at our charges as possible underpayments when the payment comes in, and really I think that might be another software application where it's not updated when it comes to the Bureau. So some hospitals don't do it at all because they've kind of just said, oh, I don't know how to do this. And then some hospitals use outdated methodology, and then on their whole ATB, they're kind of shocked that it looks like they're getting underpayments from the Bureau, when in essence, a lot of things have now bundled over the last few years and it's not an underpayment. Okay. So coding changes communicated by EOBs, but not limited to these three here. I don't have a strong on the EOB 246. Maybe I'll pose a loaded question for your team, Yvette, on, we have had, and it's usually certain MCOs on this EOB 246, comorbidities diagnosis is deleted off the bill at the MCO level, and it changes the DRG. And so the hospital's position, which I totally can, you know, appreciate, is you have a diabetic or an obese person or a smoker, and they put the diagnosis on the bill, and it does change possibly the grouper. The MCO will remove or ask for us to get the hospital to remove the comorbidities because they're not allowed in the case. Do you have some suggestions on that?
This is the first I've ever heard of that happening. We would like to see some examples of that, and then maybe we can comment, but no, if the patient is in there being treated for, you know, hypertension or morbid obesity or something that is changing the DRG, then, you know, and being treated for the allowed condition as well, then, I mean, it's part of the treating the whole person. Those should not be removed. Now, the only time I've seen, and it's only been a few times, diagnoses that should be removed is, for example, a person was in for a hernia repair, and they at the same time had an ingrown toenail.
Right,
fixed.
sure.
Yeah, that makes sense. And in those situations, you know, we can split bills, and, you know, we get other the folks involved at the hospital level, but I will make sure that we do this, because I would say it's probably at least every quarter we'll have one or two that they'll ask to have the hospital remove a diagnosis code. And obviously we don't ask the hospital to do that. So I think that's good to know.
Great.
And then BWC medical records, you know, a lot of people will send the whole chart, which might be easier, but not necessary. So again, in respecting PHI, there's really all you want to submit is that which is related to this claim. And I feel real strongly about this, including with my staff. So sometimes the opinion, the submit medical records, doesn't take someone highly skilled clinically or in workers' comp. And I disagree greatly, because you need to read through, because a lot of patients have that patient physician privilege in mind that this information isn't going to be shared So, you know, you want to send the admission history and physical. You need to send the emergency department report if that's where they entered. The op report so that they can validate what was approved, is what was done, is what is on the bill. But I mean, some of the nursing notes that the patients include or physician that they talk about other unrelated things, I don't think is necessary. All I'm asking for providers that we do on the technical side and on the professional side is what information is needed to make a solid decision if this is work-related or not, and is this procedure being cared for in the most appropriate, most efficient way with the notes that I have so I can go through it and make a good decision. So I feel like discharge notes, you know, for the Bureau, return to work is crucial. We want to see if that patient can go back to that same job, same employer, if modifications need to be met. So I feel like sending the pertinent medical is crucial. Not sending, you know, the whole chart is not necessary most times. If in fact the MCO disagrees with you and they do want the whole chart, they will ask it via directly or via an audit. So I think that's kind of important. In regard to hospital bills, this is, so most of this is a little bit redundant, but, you know, except the cases of emergency, prior authorizations must be obtained in advance. So what we'll do is once in a while we get a rub where the patient comes in to the emergency room frequently, and it's not an emergency. In fact, it might just be an urgency, or it could even be drug-seeking behavior that they come in. Oftentimes, the emergency room is in a predicament where they have to treat them and see them, but they won't get reimbursed because it's not part of it. So I think in these situations, the more we can alert not only the Bureau, but the MCO that this person has a repeated pattern, it serves ultimately the patient well. And now we have alternate programs that the patient can be channeled to. So, you know, again, we have some social obligation to make sure that we can keep the continuum of care going now that we have other options. And then I think, again, as a hospital, you don't have a lot of control over this, but the treatment of the emergency room. So I kind of same situation. Okay, so most common cases needing appeal would be the coding issues, rehab code, pain code, inpatient codes differing from allowed codes but causally related. Those are ones that will need retro C9s possibly, or some discussions. Claims in hearing status. So, you know, I want to remind everybody that they can stay in hearing status for a long time. Self-insureds are not obligated to update it. So sometimes you just keep going back only to find out it was disallowed. So you want to make phone calls on that. But we have to afford patients their due process. So if you jump the gun and send it to the commercial carrier, you need to just be prepared for a take back if it becomes allowed. We are a very claimant-friendly state. So, you know, after the first hearing, if it becomes allowed, I would say, then after the first hearing, if it's disallowed, then you could probably send it on to a commercial carrier. But again, at any time, if it gets overturned, you're going to have to reprocess that claim. We talk about manual overrides, and then post-op surgical complications requiring additional allowances. Blood clots, infections, a one-time occurrence versus a repeated occurrence. Because, you know, if you think about it downstream, all your labs will deny, your IV treatments can deny if you don't get the additional allowance, if you know it's going to happen more than one time. So we look for companion accounts so the patient doesn't get stuck with the bill, because even if it's billed as commercial, they're going to get co-insurance and some of those responsibilities, which are really climbing now for out of pocket. Okay, that's it. Now we can take questions.
Okay. And we thought we would be ending early today. So, okay, let's jump into our questions. What section of the ORC or other documentation do we need to appeal those denials. We have quite a few MCOs denying for coding that are causally related but not exact.
If you want to, I don't have the exact section of the administrative code in front of me.
So which denials were you talking about at that particular section?
It looks like they're probably, I would say, diagnostic codes that are causally related but not exact. I mean, it's in the billing and reimbursement manual for sure, but.
Is that in Ohio Revised Code or Ohio Administrative Code, or is that in the does that exist in the billing manual? That I'm not sure that's in OAC.
Yeah, we don't think that it is in rule. We think that it's just in policy. I guess I'd have some questions with respect to that. So the services would most likely have needed prior authorization. And so if the hospital had had prior authorization, but then the MCO subsequently denied the care, I would appeal from that perspective that the prior auth was obtained and demonstrate the causal relationship. The MCOs have the ability of putting an override on the bill to let us know that this is something that is causally related to the service to allow it to go through.
Yeah, and that would be, right, I agree.
Yeah,
that would be my suggestion.
Okay. When we receive a non-payable status denial codes, this mean pending medical review? When we receive a non-payable status denial code, does this mean pending medical review?
I would say no. It's not in a payable status.
Yeah.
It could be a non-allowed code being utilized would be my guess.
Yeah, I wouldn't think that would mean it's pending medical review. No. If a claim is submitted to the MCO before it is in allowed status, will the MCO automatically reprocess the claim when it is in allowed status?
So
I can, go ahead.
Well, it's our understanding that yes, the MCOs are supposed to automatically reprocess when the claim goes into an allowed status. We have heard in some provider forums that in some cases, some MCOs were not doing that. And what we had asked was for examples, if you could submit those to the provider call center so that we could take a look at those. But in a couple of cases, what we had found was that it was a timing issue, so that the claim was an allowance, it got transmitted to the MCO, and the MCO received the bill on the same day as the allowance, but their system was still recognizing it as in pending status. And so due to that timing error, it did not automatically reprocess, but that doesn't happen that often. But we could look at those individual instances where it has happened, because it's supposed to be automatic, and the MCOs, that is something that they're measured on.
Okay, so if it is happening and hospitals are seeing it happen, then they should report it to the provider call center, you're saying?
Correct, yes.
Javette, when did you meet with them to discuss this?
So we have a medical symposium each year, and for the past 2 years, we've had a billing component to that for the billing personnel of hospitals and physician practices. And it was during that session, which was in March of this past year, that's where we had quite a few providers asking us that particular question, where we did some research around it.
That's good. That's good to know, because we do experience that, to be honest with you. Some MCOs are great, but other MCOs will utilize the, I'll use the word excuse, that the UB has to be dated after the allowance became allowed, if you will, after the claim became allowed, and so they'll want a new UB submitted. So it's good to know that they are supposed to automatically extract it and resend it.
Okay. Great question on the next one. When do we combine accounts that have same date of service? Could you advise on that, Yvette? When should they combine accounts that have the same date of service?
So you're talking about outpatient services?
Could be outpatient, inpatient.
And by account,
maybe,
are you talking about like an injured worker would have two separate hospital medical record accounts, or are you just talking about two different bills?
I would assume they're talking about two visits on the same day for the same hospital. So same MPI, same provider number, same medical record number. It could be two scenarios. They came into two different outpatient clinics for the same day, or they were inpatient, got discharged, and came back for an outpatient appointment in the afternoon, or vice versa in the morning, and then were made inpatient. Radiology, lab.
Yep.
Should those be combined?
For pricing, yes. You know, otherwise the MCO would have to, so if it's outpatient as an example, and you're submitting physical therapy and labs on two separate invoices, the MCO would have to do an adjustment to have those combined.
Okay.
Because that's how OPPS prices.
Are there rules, and I'm sorry, I actually don't know this one. Are there rules on outpatient, combining an outpatient into an inpatient within so many hours for BWC? I should actually know that, and I don't. There are not, are there?
No.
Okay. Okay. So if it is outpatient versus inpatient, then those would be submitted separately, correct?
Well, no. If there's an outpatient service at the same time that a patient is inpatient, is that because the hospital didn't have the equipment to provide and they transported the patient down the street to get a CT and then back, or is that what we're talking about?
I guess I should have clarified. So let's say no, because in that case it definitely would. I assume it would definitely be combined if it's the same exact date of service. So if the patient was inpatient at XYZ hospital and then they either went to another department and somehow that generated an outpatient claim, or as you said, were transferred for a specific service maybe to another facility within that health system, or outside of that health system for a service that they couldn't provide where they're inpatient, then that would also be on behalf of the inpatient facility to reimburse for. But I'm talking about, let's say Peggy Sue comes in the hospital January 1st for outpatient clinic, and then 2 days later or the next day is made inpatient. Those the Bureau do not want combined, correct? Because they're on two separate dates of service.
You know, we will have to check on that specifically to see what our programming is, because I know we have been discussing that recently with respect to up to 3 days prior to inpatient, and I think up to 14 days after inpatient for lab services. So I'll have to get back to you on that one.
Okay, that'd be great. Next question, with the recent changes in MCOs due to open enrollment, if the first MCO authorizes a procedure through the C9, but by the time the claim is submitted, the MCO changes, does a new C9 need to be submitted to the new MCO?
They're supposed to honor it.
Correct.
Okay, so the C9 should be honored from the previous NCO.
Yes.
Okay. We had a patient that would not sign the medical release form, so it left the BWC claim pending. At what point is it okay to either bill the patient or their other insurance coverage if they are not giving the info requested? We also have filing limits with other payers we would like to meet if needed.
So my suggestion, and then Yvette, you can challenge it. So if a patient won't sign the FROI or the medical release, there's usually a suspicion as to why. Okay, maybe they didn't want to consent to drug screening or something like that. Then to me, it's a patient responsibility. It's their bill then. Then they're not truly saying it's work related if they won't sign the FROI or the authorization. And it's not a commercial situation if they're alleging that it happened at work. So again, we want to move our thoughts to name the right payer, not how are we going to get paid. So if I would not move it if they had commercial insurance. If they said it's work related, but they don't want to sign, then they can pay for the bill themselves after receiving the treatment. That would be my recommendation.
And we agree, Sherry.
Okay. Which MCOs can accept claims electronically? Oh,
well, they're all supposed to.
That's right.
Yeah, I don't think any are not on record as being able to accept claims electronically, correct?
Correct. No.
Now, if you're having issues with your clearinghouse getting claims to those payers, that might be something that you first want to reach out to your clearinghouse on and have a conversation with them.
Right.
And then if that is unresolved, it might be possible, it might be appropriate for you to call the provider claims center at BWC and have that discussion with them and make sure they are aware that there's an issue through a clearinghouse in Ohio with an MCO, so they can back into that and help you with that. Would you agree that?
Yes.
Okay. Should we hold claims until they are allowed status, or can we submit them once coded regardless of status? I think we answered this earlier. We definitely don't. Sherry, meaning Argo, does not recommend holding a claim longer than 3 days. The Bureau has followed up and said they agree with that. They believe that should be submitted to the MCO or BWC. They have coders that can code those claims.
Right, and even so, that's even in just determining the claim. And then I definitely would not hold it, because we also just heard that in theory the MCOs, once it becomes from alleged to allowed, are supposed to pull the bill and resubmit it. So definitely do not hold them until it's allowed.
So 2 ER visits on the same date need to be combined. We are following Medicare OPPS rules for combining. Yes, I would agree. I would agree that you are, I would let Yvette and Lisa follow up on that and update us, and I can get that out to the hospitals. But yes, I would agree that 2 ER visits on the same date of need to be combined. Would you agree with that, Yvette, or no?
Yes.
Okay. Okay. But they will follow up and get us some maybe a little bit stronger guidelines, or take that back to the entire policy team and get us something in the future. If the MCO will reprocess a claim that was filed before the claim was in allowed status, will they also automatically reprocess a claim that was submitted before an additional diagnosis was allowed, or must it be resubmitted? It must be resubmitted, correct? Right. Yeah, I would agree. You would agree with that. So if it's an additional diagnosis, they would not go back and process that. You would need to resubmit those.
And most times, right, add the medical with it.
Or an allowance.
Right. Right.
If you're requesting an allowance, as Sherry, right. I love Sherry's. My favorite Sherry antidote on BWC is patient came in for surgery today and then returned 2 days later with constipation. And hospitals trying to get that constipation diagnosis added as an allowed diagnosis. That would be an area where you would ask for an allowance, because clearly you would not want to add constipation as an allowable diagnosis.
Yes, you would ask for an override. Hopefully it's a one-time incident and not a chronic thing.
But it would be causally related, because their constipation was from
narcotics.
Yes, the narcotics from the surgery. So that is a great, vivid story that will stick with you. Yeah, and it is real life, but it's these funny stories that will stick with you, no pun intended, that will help jog your memory on when something is causally related, but you don't want to add it as an additional diagnosis. So just trying to make this as fun as we can.
Such a claim to fame. Thank you.
Right. Yeah. Sherry's claim to fame is constipation, for sure. Does BWC follow the MCR guidelines for the 72-hour rule when combining outpatient to inpatient? I'll let Yvette answer that, but my thought is at this time, no, but they are looking into that.
Correct. That's what I want to just double check. I believe that we're following Medicare, but I want to double check on that.
Okay. So I will get that out to everyone on Finance News when they follow up and get that to us. Great. These are great questions, guys, and we really, truly appreciate these. I know we're kind of having fun with some of these, but these are great questions. I have patients who present at the ED and then are later seen at one of our urgent care centers on the same day. Do I file 2 UBs with a condition code or combine my accounts and file on 1 UB?
If it's same provider number, you still would combine them, right? I mean, if your urgent care is billed under a different code or a provider number, if you can bill it as a unique encounter.
I would agree. Would you agree with that?
Yes.
If it's the same provider number, you should combine them. If it's a different provider number for that urgent care, then I would bill those on 2 separate claims.
Otherwise, they're not going to pay. If it's the same provider number, they're not going to pay it anyhow.
Right. And if you're on Epic, that should trigger for your combined work queue if it's the same provider number.
Right.
In follow-up to a previous question where the BWC claim was pended because patient was not provided information, what does a provider do when the patient's only coverage is Medicaid? Technically, the patient should not be billed. You're absolutely right. Statutorily, that patient cannot be billed for service. Will BWC eventually disallow the claim for lack of patient response? That's a very hard question. It's a question I would ask Yvette on.
Yeah, I am not sure that we know that. We would have to check with the claims folks to see how they would handle that.
But I guess my challenge is it's still the patient's responsibility. I understand they have Medicaid, but if it's not a commercial insurance issue, if the patient's declaring it's work related, and they won't sign or give the information,
you cannot bill the patient in the state. You can't bill the patient federally. It's a federal mandate that you cannot bill the patient regardless if they have Medicaid, if it's a statutorily covered service. So even though the patient is holding that claim up by not signing, you can still not bill the Medicaid patient.
Really?
In any state.
For any reason.
For any reason, unless the service is not statutorily covered by Medicaid, which there are very few services that are not statutorily.
So Medicaid will pay for a patient's ER visit that he or she says is work related.
They would, but they also could turn around like a commercial payer and take that payment back if it's BWC related. So it would essentially in that case be a COB issue for those of you on the phone who are, most of you are familiar with Medicaid. This is the same catch-22, guys, that you have when a patient, and to give Sherry and Yvette some backfill here if they're not aware, this is the same exact scenario that you have when a patient has a commercial insurance. Commercial insurance is showing that they are not primary, and Medicaid is showing that they have a commercial payer and they are not primary. So you have 2 secondary insurances at that time. So that patient needs to resolve that COB issue with the commercial insurance. So they'll accept that claim primary. You cannot bill that patient. The patient is on the hook for for resolving that issue before you can bill that claim. So it is a hard spot for the hospital to be in, but you could not bill the patient in this situation. Mm-hmm. Now, Yvette can follow up and see if BWC will eventually disallow the claim for you for lack of response.
Because
that, go ahead and Medicaid.
Yes, and that is usually what I've seen, where the Bureau will disallow it because of patient noncompliance. Then you can, yes.
Yes. Now, if Yvette confirms that her folks will just allow that for lack of noncompliance, then that would be the perfect opportunity for you to bill Medicaid. And if Medicaid came back and audited that account, saying there's a COB issue, you can prove that BWC disallowed that. So that would be, if they can provide that, that would be great, something great for your records. Can't you have the Medicaid patient sign an ABN? Ohio Medicaid has a process for this. Yes, you can, but the ABN is only good if that service is not statutorily covered. So you cannot have a patient sign an ABN for a service that is covered by Medicaid and bill the patient, just so you know. When it comes to drug testing on the initial injury date, does the drug testing get billed directly to the employer, or will BWC cover that?
We suggest billing directly to the employer because it's policy specific.
Would you agree, Beth?
Yes.
Okay. MCR has had issues with denials due to old work-related injuries on the common working file. When does the workers' comp close out, or does it?
Sean.
Do we know when those close out, Yvette?
If they're not receiving medical treatment, active medical treatment, I think there is a limit, but I am not certain of that, what the limit is. Yeah, I'll check on that.
Okay. There are new guidelines in the MCAD manual for non-compliant patients, i.e., when we have tried to contact the patient for previous commercial insurance coverage, patient can lose their benefits. That is absolutely true. The Medicaid manual for non-compliant patients, that's absolutely true. You need to report those situations to their county caseworker, and it's up to the county caseworker to go ahead and back off the coverage for that individual if they're non-compliant with commercial insurance. Keep in mind, though, and that's actually outside of this purview for this webinar, but I don't believe the county caseworker will term benefits for pregnant women or children under those situations. But they will, if you can get in contact with the county caseworker, they have been tasked with getting the patient to be compliant with commercial insurance, or in this case, BWC on those scenarios. That is not the Medicaid at the state level, that is at the county level. You are correct. Two more questions, and then we're done. We're right at the 12 o'clock mark. When we combine 2 ER visits on the same day, do we add the 27 modifier on the second visit? I think that's a question for BWC. Lisa, do you know if Lisa or Yvette, do you know if they are to add the 27 modifier on the second visit?
We accept modifier 27. So if you're following the Medicare guidelines with respect to the use of it, then yes.
Yeah, I would agree. I would think you would definitely use the 27 modifier for adding that on the second visit for multiple outpatient hospital evaluation and management encounters. Okay. And then the last one is very technical. What is included in the DRG rate of the Medicare payment formula that you shared in the proposed IPPS rule for 2019? Is it just as simple as a weight times hospital base rate, including capital? Is dish included? Is disproportionate share included?
Yeah, so we purchased the pricer, and that gives us the exact pricing that Medicare would pay for that same claim. It does include dish, and then we apply our payment adjustment factor. So the change for 2019 is just where the payment adjustment factor, when it is applied.
Great. So to reiterate for the hospitals on the call, so yes, it would include your hospital base rate times your relative weight for your APR DRG and your dish calculation with your IME GME payment for that DRG rate. So starting this year, and please correct me if I'm wrong, Yvette and Lisa. So starting this year, Bureau of Workers' Compensation will take that, what you would be paid by Medicare, multiply that by your payment adjustment factor to equal the 114%, and then any additional add-ons for outliers or for your technical piece would be in addition to that. It would not be, those two add-ons would not be included in the multiplier for the payment adjustment factor, just your DRG rate, your typical DRG rate that are included in your Medicare payment would be the only thing subject to the quote, markup, that's Sean's terminology for the payment adjustment factor. Does that make sense? Did I explain that right, Yvette?
Yes. Yes.
Okay. Please let us know if you have any questions on that proposal. The whole idea would be, as Yvette and Lisa said, on that change in multiplying just the payment adjustment factor by the DRG would not be to incentivize hospitals or to incentivize care in an extenuating circumstance to benefit hospitals to hold a patient for an outlier payment, just as Medicare does not incentivize hospitals to reach that threshold for outlier payments. BWC is going down those same guidelines for hospitals, no difference really. So I think we're all in agreement that their new methodology is best case for BWC, for Medicare, and for Ohio hospitals. And in honesty, running through the numbers, and Lisa and Yvette can contest to this, there's not a lot of situations where hospitals do hit that outlier mark for a BWC patient. So this really doesn't have a big impact. It just tightens up that payment process.
It does, and it forces hospitals to get more aggressive on the continuum of care. So on those catastrophic cases, they're going to need post-hospital care somewhere. So it just makes hospitals a little more attentive to that. And these go in effect February 1st of 19, correct?
Yes.
Okay, great.
Okay, well, we appreciate everyone's cooperation and hanging in there to the end. Hopefully you found this session very helpful. I truly, truly appreciate this new format that the Bureau of Workers' Compensation and Argo Health, with Sherry here in attendance, and all of the hard work that her team does on the back end at Argo Health. Please reach out to me if you have any questions on this session. The recording from the session, along with the slides from both presenters, will be up on our website by the end of the week, hopefully within 48 hours if we have no issues. Thank you for that, and have a great day. Bye-bye.
Everybody's dropping off. They must have quit.